All right. Hello and welcome to today's webinar, Mastering Medicare, a deep dive into outpatient rehab therapy coverage. My name is Mary Sue Gardner, and I am a registered nurse in the Provider Outreach and Education Department, and I'm going to be your educator for today's event. And I am joined today by my fellow nurses on the Provider Outreach and Education team that are going to be helping with the question and answer portion of today's call, as well as if any technical difficulties should arise. All right, on the screen for you now is our disclaimer, and in a nutshell, our disclaimer says, we prepared this education as a tool to assist you as providers and tell you the Medicare laws, rules, and regulations, but they often change. And so those laws, rules, and regulations are housed on CMS's website. And it's your responsibility as a provider to make sure that you're following the most current laws, rules, and regulations. So what I'm telling you today is as current as it is for today. But if those laws, rules, and regulations happen to change tomorrow, it would again be your responsibility to make sure you're following tomorrow's laws, rules, and regulations. We'll make every effort to provide that information to you if laws, rules, and regulations change. Also, CMS prohibits recording of this presentation for profit-making purposes. So if you happen to be recording it or screenshotting it, we ask you not to do that. We are recording it for you, and we will post it on our YouTube page as a encore of this event. Now, this slide just contains some acronyms that I'll probably say during the course of this presentation, or you'll see that are built into the slide deck. So if I happen to use an acronym that you are not familiar with, please refer back to this page. My computer's not playing nice today. Here we go. Okay, so my objective for today's event is for you to learn about the coverage criteria, the documentation requirements, any prevalent pitfalls that are being identified by our medical review department for outpatient rehabilitative therapy. This includes physical therapy, occupational therapy, and speech-language pathology services, which I'll refer to as PT, OT, and SLP through the course of this presentation. And I'm going to accomplish this today by doing a comprehensive review of the coverage criteria and discussing those documentation requirements. We're going to also review some of those common errors and how to avoid them. And then allow you time to ask questions and provide answers. So even if you think you know all the laws, rules, and regulations, it's always good to go back to the basics and re-review. We have people on this event that have 20 years experience in Medicare and people that are brand new to Medicare. So this event is really tailored to everyone's needs, whether they're a first-time learner or it's a refresher, in training for them. So we're going to start out by talking about how to locate the rules and regulations and knowing the rules and regulations and where to find them. So as a practitioner, knowing the rules and where to find them is probably one of the most difficult tasks. Your practice acts can be found in your national and state associations information. If you're new to practice, I highly encourage you to join your national and state associations. They're actually the ones that are fighting the fight for you. If there's changes that need to be made to laws, rules, and regulations, your associations are the ones that are bringing those to Congress and lobbying for change for your industry. Their websites also host a plethora of information on regulatory changes and practice acts and news, et cetera. So really, the first thing is know who your association is, know your national and state associations, and join those if you haven't already. Now, CMS regulations are hosted in the internet-only manuals on CMS's website. And we're going to be actually reviewing those today, and that's why we're all here. As your MACs may also have local coverage determinations that help to drill down the laws, rules, and regulations further and give additional information. So if you're on this webinar, then I can assume that WPS is your MAC. Should you go to WPS GHA and look at the information we have on there, you're not going to find an LCD specific to PT, OT, or SLP, or outpatient rehab services. But our website does have info on reviews that we're doing, documentation requirements, et cetera. Plus, if CMS makes any changes, we announce those as soon as we know them. So become familiar with your MAC. If you move to a different state and you stay in your current type of practice, first thing you should do is find out who your MAC is and look and see if they have any local coverage determinations that are specific to you. Finally, there's private payer regulations, and this includes your Medicare Advantage payers. So should you have any questions on what they allow for coverage, you have to go back to those plans and contact them. Advantage plans have to cover what traditional Medicare covers, but not in the same way. And we'll talk about that a little more as we go on. So as we move on, here we go. My computer's being really slow, and I apologize for that. Let's now talk about some of the coverage of outpatient rehabilitative services. As Medicare, we have different parts of the Medicare program. Part A, Medicare, is facility-based coverage. And that coverage includes like inpatient hospitals, skilled nursing facilities, inpatient rehab facilities, and in hospital care, but it also includes coverage of outpatient services that are provided from a facility, like outpatient rehab from a hospital or Part B rehab in a skilled nursing facility. Medicare also has coverage for outpatient therapy services under Part B. This includes office visits in a physician's office or a therapist's office or a private therapy practice. Outpatient rehab like an ORF or a CORF and home services are included under the Part B payment. Finally, kind of like we discussed a little bit before, Part C is Medicare Advantage plans. Now, Medicare Advantage plans combine Part A and B and sometimes include Part D, which is prescription drug. And they're administered by private insurance companies. Now, remember, they must cover at a minimum the services of original Medicare, but they don't have to cover it in the same way. So, for instance, they may not cover as many skilled nursing facility days as traditional Medicare, or they may cover more skilled nursing facility days. They may have more co-payment days for your beneficiary. So it's important if your patient presents to you and they have a Medicare Advantage plan that you are following that plan's laws, rules, and regulations as well. Okay, so as we move on to the laws, rules, and regulations, the Medicare regulations are housed on the CMS site under the Internet-Only Manuals, or IOMs. And those IOMs are organized by functional area. So for instance, 100-4 is all things claims processing, how to bill, a claim, how to get it into the system, if there are modifiers needed, etc. While 100-02 is all things benefit policy manual. The benefit policy manual is where you learn about coverage criteria and documentation, etc. So as a clinician, I tend to spend most of my time in this manual, and this is the one we're going to focus on today as we talk about coverage of therapy services. So as we move on to this slide, you're going to see that this slide contains information about the benefit policy manual, which for therapy, outpatient therapy services is 100-02, Benefit Policy Manual, Chapter 15, Sections 220 to 230. Now, this section is specific to outpatient therapy services. However, the outpatient therapy regulations form the foundation of coverage for therapy provided in any setting. So if that setting is silent on coverage or documentation requirements, then you fall back on the outpatient regulations. So for instance, if you're going to provide skilled therapy for a patient that's in a SNF Part A stay, you would need to start with the regulations outlined in the outpatient section that's listed here. So in sections 220 and 230 of Chapter 15, and you also need to look at any specifics in Chapter 8 of the Benefit Policy Manual, which is coverage of extended care or SNF services. So here you'll find that there's a difference with how physician certification must be obtained. And I am going to just bring up the Medicare Benefit Policy Manual. And I'll actually just go back to the homepage for cms.gov. And once you get here, if you click on Medicare, Regulations and Guidance, and you go to Manuals, and you go to Internet-Only Manuals, this will take you to that list of IOMs. I am going to go to the Benefit Policy Manual. I am going to scroll down to Chapter 15. And like I said, Chapter 15 is all things outpatient services. I know what page I need to go to, so I'm going to go to sections 220 and to 230. That's all of the information on coverage of outpatient therapy services. But I knew what page I was on or needed to go to, so I just quickly went to that. So if you scroll through this section of the regulations, and you're going to see some definitions here and how different things are defined, such as how is a clinician defined, how is an evaluation defined by Medicare, what is a maintenance program, etc. These give all of the definitions. You're going to see this next section then gives you references. And what CMS has done here is they have taken the references for different places that therapy can be rendered and given you that information. So again, you start with the basics in section 220 and 230, follow those regulations, and if there's something more specific regarding the place of service that you are working at, then you link out and find out where you need to also look at additional information. So let me minimize that again, and hopefully that made sense to everyone. All right. So as we move on, I wanted to, again, give some of that background information, especially for those people that are new in the industry or newer in the industry. For those of you that have been around, just a nice little review of how to find the regulations, where everything is located. So let's jump in and start talking about the basic criteria for outpatient therapy coverage. Before I jump into this, I want to note that if you're following along with this slide deck, that your slide deck may have said basic criteria for OT coverage, and that wasn't meant to mean just occupational therapy. It should have instead said outpatient therapy coverage. I didn't catch that before it was posted, so just note that this is the four basic criteria for any outpatient therapy, be it PT, OT, or SLP. All right, so there are four basic coverage criteria that must be met in order for Medicare to consider coverage of outpatient therapy services. And these include, it needs to be a need-based service. So what that means is it requires the services based on the individual's needs. That individual needs you, and they need your license and your expertise only to make them better. We're going to break these all down a little further as we move on. The other basic criteria that must be met is that you must render your services under an established plan of care. Your plan of care can be established by your physician or non-physician practitioner, but it generally is established by a therapist. In my 23 years in Medicare, I have only once seen a plan of care that was established by a physician. The care must relate directly and specifically to the plan of care. So that means you can't be providing care that you didn't identify in your plan that you were going to treat. If an issue comes up with the patient that needs to be added, then you need to update your plan of care. Make sure your physicians know about it, make sure your physician recertifies it, and proceed in administering your services under your established plan. Your patient also needs to be under the care of a physician. So services must be provided to a patient that has an established physician that agrees to certify the plan of care. Now, that doesn't mean you need an order. Once direct access came into play, Medicare changed their regulations as well, and an order is not required. But we still want to see physician certification. So how do we see that? We see that by having you get a certified plan of care to make sure that the physician is involved. So physician certification helps to meet these conditions that are listed above, 1, 2, and 3, showing that it's need-based, showing that there's an established plan, and that the physician is involved. The other thing about your physician certification, it must be legible. And the physician's signature, be that electronic or handwritten, the signature and the date must both be legible. So let's break these down and discuss them in detail a little further. So need-based services. Need-based services help you establish medical necessity. So the service must need you, your license, your expertise to really safely and effectively administer the services to the patient. So when a patient presents to you, your first questions to yourself should be, why does this patient need me? What about my expertise can be provided to get this patient hopefully better or reduce risk of further deterioration, et cetera? Ask yourself these services or these questions like, Are the services I'm going to provide reasonable for this patient to reach their desired level of relief or functional improvement? Are they reasonable in the amount, frequency, and duration that I think they should be provided in? Is that amount, frequency, and duration necessary for this patient? Are we reducing the risk of further deterioration, such as a maintenance program? If we are, what are we doing that requires skilled services and skilled expertise? Are the services that I'm recommending actually skilled? So do they need me? Do they need my license? Do they need my expertise to carry out, develop, carry through, oversee an assistant, or, whatever? Are they routine or repetitive? Can they be done by someone that is not a licensed therapist? So if the services that you're recommending can be done by someone that's not a licensed therapist, then perhaps they don't need you. Perhaps they aren't skilled. As we move on to evaluation and plan of care. So we said that services must be rendered under an established plan of care. So your plans of care need to be individualized for your patient. And again, established by generally the therapist, but they can be established by the physician or non-physician practitioner. What we mainly see is that the physicians will send recommendations or an order to treat a patient and may contain some recommendations for treatment. And then when it comes down to the actual evaluation and plan, that's usually then established by the licensed therapist and sent back to the physician that says, here's how I'm going to do what you recommend, and here's really all the things that we're going to do for this patient and my recommendations of how it's going to happen. Your evaluation plan should be established before you start treatment. That doesn't mean that you can't evaluate and treat on the same day, because you are evaluating and you are writing your notes and you are making all the necessary documentation requirements as you're looking at that patient and treating them at the same time. So just note, before your second treatment happens of the patient, your plan of care needs to be made formally. Your evaluation and plan of care need to be periodically reviewed, and that's done via the progress notes, and we're going to talk about those as well. You as a therapist or a physician or non-physician practitioner are the only ones that can make changes, updates, etc., to your evaluation and plan of care. So an evaluation and a formal plan cannot be done by anyone less than you or the physician or non-physician practitioner. And some of the things it needs to contain are diagnoses, long-term goals, type, amount, frequency, and duration. So sometimes there's a need for a reevaluation. Now, reevaluations are not routine or recurring services. So you should not be doing the reevaluation and billing it to Medicare every time you do a progress note, or doing a reevaluation at the end of every month and billing it to Medicare. Reevaluations, again, not routine, not reoccurring. They're only covered if the documentation supports the need for it. And that need would include if there's new clinical findings or if there's some sort of significant change in the patient's condition. If those things were to happen, and you say, well, this plan just really doesn't work for this patient anymore, or I have to add all new goals, or based on this new illness or injury that is presenting, we need to reformulate all these goals or scrap them and start over, then yes, you have the right to do a reevaluation and bill that to Medicare. You also have to send that new or reevaluation to the physician so he or she can update it and give you a new certification. Continuous assessments such as progress reports are not billable as reevaluations. You should constantly be reassessing your patient, and that's why you do progress notes, to compare where were they at the start, where are they 10 days later, where are they in another 10 days, or sooner if you want to do your progress report sooner. But again, those should not be billed to the Medicare system as a reevaluation. Now, if there are, what do we consider significant changes to the plan of care? Significant changes, and I kind of said this, are anything that requires a revision to your long-term goals. Anything that's going to make the plan that you put in place different, and perhaps change all of your treatment goals, your short-term and your long-term. Now, just adding a modality of service or increasing therapy by a day or decreasing it by a day, those are normal and expected changes. Things happen, and we know that, hey, this goal was completed early, so let's establish a new goal, and as long as it's within our treatment recommendations. So those are normal and expected things to happen. When it's a significant change, like some other type of life-altering event or a new illness, injury, accident, that really causes that to change, those are things that we would consider significant. And again, those changes can only be made by you, the therapist, or by the physicians. So generally, they are unexpected changes. So if you have something that you didn't expect to happen, that may prompt you that this is a significant change that may require a reevaluation. If you get if you reevaluate, you also need to recertify. Okay, care of a physician. So in order to support that the services are provided under the care of a physician, a few things need to happen in accordance with the Medicare regulations. Again, we don't require an order. If you get orders, great. Keep them, scan them into your electronic medical records, or keep them if you're doing paper records. Make sure you have it and, keep it, and it becomes part of that permanent chart. But what we do require is that certification by the physician for your plan of care. So certifications are really just an approval of the plan. It's the physician saying, yes, I agree that you have made the best choices for my patient and how you are going to treat them, and I agree that you can treat this patient. Certifications and recertifications can be completed by the physician and the non-physician practitioners. Medicare also allows optometrists for low vision services and podiatrists within the scope of practice as authorized by state law. So we do not look at all the state practice acts, but if you are, if your state allows podiatrists to certify the plan of care, then Medicare will also recognize that. All right, so that was a handful about the coverage criteria, and those are the basic coverage criteria. And now we're going to move on to actually talking about the documentation and how we support these coverage criteria in our documentation. So on the screen, there's some general principles of documentation, which hold true for every industry. Your documentation needs to be clear and concise and complete. It needs to be correct for the right patient, or beneficiary, whatever you want to call it. Comprehensive. We don't want you to write a book, but we want you to give us enough information that it paints the entire picture of your patient and exactly what you're doing and why. There are some components of documentation that are required by Medicare in order for you to support your services as medically reasonable and necessary. Now, here's one thing I want to tell you as providers. Medicare is probably one of your most strict payer sources, and we probably require the most out of your documentation. So instead of keeping different documentation for different payer sources, tailor all your documentation to your strictest payer source. So if you are meeting the requirements for your strictest payer source, you're going to probably always meet the requirements for those that are not as strict either. So if we require you to have certifications done more frequently than Blue Cross Blue Shield, I would just continue on with the Medicare schedule for all your patients. And that way you're never going to miss out on, a documentation component. So things that we require you to have an evaluation and any reevaluations when they are necessary. We require to see your overall plan of care, and that plan of care has to contain goals. You, again, have to have your plan of care certified by the physician or non-physician practitioner and recertified when it's necessary. We also require progress notes or progress reports, and those are required every 10th treatment day. And the progress report includes a discharge summary. Another requirement is treatment notes for each date of treatment, and those treatment notes must contain actual minutes of the treatment provided, not just time in and time out to the therapy area, therapy center, office suite, whatever it is. We want to know how much time was spent in therapeutic exercise, how much time was spent in manual therapy, et cetera. Evaluation and plan of care can be one document, can be two documents. We really don't care. We just need to see that there's an evaluation and plan. The evaluation is really essential to develop your overall plan and to set your goals and, start deciding on and selecting the interventions you're going to provide. Your plan must be consistent with your evaluation. Again, established by the therapist or physician, has to have those functional assessments, any measurements. It needs to relate to your plan, contain therapy and medical diagnoses, long-term goals, again, type, amount, frequency, and duration, and it needs to be signed and dated with legible identifiers of who established it. So again, one thing I encourage you is to keep the words objective and measurable in your mind. Anytime you can document in objective and measurable terms, especially when it comes to your plan of care, it will only behoove you to do so. Anything that contains a length, a weight, a measurement, an amount, a percentage, etc., make sure that's how you are documenting, because I can see the difference in a progress report when a patient has had a service reported in a percentage, and now in the progress report I can see that percentage has increased by X amount. That shows me the services you provided are making a difference to this patient. But if you document in subjective terms and tell me the patient has pain, and then in the progress note the patient's pain is better, that means nothing to me. I don't know what degree of better it is. So again, take away those two words, objective and measurable, and whenever you can document in objective and measurable terms, do it. All right, reevaluations. Again, the documentation of those is required if you do one and you have a billable reevaluation. Again, it's not routine. Should only be done when there's new findings or significant changes, usually unanticipated. And again, when that occurs, it is billable to the Medicare system. So your reevaluation looks pretty similar to your evaluation and plan. It just gives us the updated goals, the new goals, the new diagnoses, if there happens to be one, new amounts, frequencies, durations, etc. All right, documenting certifications and recertifications. Where can a physician document their certification? Anywhere. Actually, it can come in the form of a progress note or an order. It can be a signed and dated plan of care. That's usually what we see in outpatient therapy services. So there's no specific form that you have to document on. Other places of services may have different certification requirements. And if they do, you need to follow those requirements for that place of service, such as skilled nursing facility. The certification recertifications are a bit different when it comes to skilled nursing facilities than they are when it comes to outpatient therapy services. All right, the timing of your certifications and recertifications. So what would we expect to see in your documentation? Your first certification should be done as soon as reasonable and practicable, and that's how it says it in the regulations. But what that really means is within 30 days of that initial therapy service, you need to get the physician's signature for certification. And then subsequent recertifications are due either every 90 days after the initiation of the treatment, or the length of the certified duration, or when there's significant modification to the plan of care. So what does that mean? Your initial certification, if you feel that this patient needs treatment for 90 days, is good for 90 days. If you send your plan of care and it says 3 times a week for 4 weeks, then your plan of care and certification requirements are done at the end of 4 weeks. So at the end of 4 weeks, if you find that that patient needs more services, then you would have to send it again to that physician. So the length of the certified duration. Or as we've said before, if there's a significant modification to the plan, an unanticipated change that causes you to do a reevaluation is going to also force you to get a recertification. Progress reports. Medicare requires you to get a progress report at least once every 10 treatment days. It can be done sooner. It just cannot be done over. And your progress reports cannot be written by an assistant. The progress reports can only be done by the licensed therapist. Now, your assistant can give you information about how that patient responded to treatment during the week under them, but they cannot do the formal progress report. If they do, we as your Medicare administrative contractor are probably going to deny it if we review it. This is your time to assess your patient's goal, to assess your patient's progress, to decide if your treatment plan needs any revisions or changes or updates to your goal. This is when you're justifying the necessity of your services and why it requires you and your license and your expertise. Remember that the discharge note is part of the progress report. Your progress reports don't require physician signature, so you don't need to send for recertifications. We often see that providers sometimes send the progress report to the physician. If that's your standard of practice, that's fine. You don't have to have the physician sign it. That's only required when it's time for your formal recertification. All right. So your treatment notes and your daily notes are your next component of documentation. As your Medicare administrative contractor, we require your daily treatment notes as a record of all your treatment. So things that are required are the date, the treatment or intervention, the minutes, and the signature and professional identifier of who did that. So things that may also be included that we really encourage you to include is the response to treatment and any subjective information, including complaints. So on your screen, you're going to see here is a daily treatment grid, and this is fine for you to do as your daily treatment notes. However, it doesn't allow you, a grid like this does not allow you to capture any of this information, which is really important for the day-to-day interactions with your patient. Like, what did they say? What are they doing? How are they actually feeling? You know, that subjective information that's a need to know that may help you make changes or updates to their overall plan at the progress note aren't captured in something like this. So although this is great and this is what we use to compare what you build to Medicare, it doesn't give the whole picture. So we really encourage you to include additional information, especially when there's something, your patient comes in with a new complaint, new symptomology, or they're miraculously doing way better than expected on their next visit or way worse than expected. You want to be able to document that somewhere. So some strategies to aid in decreased denial. We reimburse when your documentation and your claim form really equal the provision of medically necessary covered services that follow the guidelines. So we look at your documentation. We again go back and look at the minutes, the CPT code bill, make sure that we can find it in the documentation, we can find it on the claim form, and that you're following your plan of care and that you're following the Medicare regulations. If you're not, then we're probably not going to pay for it. If your documentation is not legible or it's not relevant or it's not correct, we're not going to pay you. So make sure you are doing periodic reviews in your own offices and make sure everyone's documentation is legible and relevant and correct and complete. Yeah, must be able to defend the service and the CPT code bill. And again, whenever feasible, objective and measurable documentation, whenever feasible. Remember, you could be called into a court of law at any time, and you have to be able to defend what is on the paper. And if the judge and jury can't read it, most likely it's not going to be favorable for you. Or if you don't have enough information to support the services that you actually provided, it's not going to be favorable for you. I want to take a little bit to talk about the difference between restorative and maintenance. So restorative therapy is really, well, Medicare covers both. Let's just start by saying that. We cover restorative, we cover maintenance. Restorative is when there's a potential to improve, and improvement is usually going to be done in a predictable amount of time. And you give us that predictable amount of time by setting your amount, frequency, and duration 3 times a week for 4 weeks, 3 times a week for 12 weeks, 3 times a week for 90 days. And then you stop therapy when maximum improvement is obtained. Maintenance, however, is a little bit different. And maintenance is really to slow the deterioration or prevent decline in a patient. And generally when they have a chronic condition, usually things like MS, Parkinson's, et cetera, that are going to come to you for therapy repetitively. So a maintenance program is a program that you set up, and it has to still be skilled. It has to have skilled interventions. It has to need you. It cannot just go on forever and ever doing the same thing that could be done by a home exercise program or carried out by someone with less than your license, just because the patient does well when they come into the therapy office. We all do well when we go to the gym on a routine basis, you know, and keep our fitness level at a good level. And so if the services that you're providing are really just at a fitness level, they don't need you and your skills. So if you're going to provide a maintenance program for a patient, think about what requires me, my skills, my license, my expertise. What do I need to get in to and do with this patient to prevent further decline? Have they gone from using a cane to now needing a walker and an AFO boot? Are we making sure that, you know, the AFO is fitting correctly, that their stride length is correct, that they're using their walker safely and effectively? We're training them on new skilled things. We're watching them. We're carrying over, showing the family caregiver, and then we're letting them go because they're going to come back. So we're trying to restore to prevent further decline or slow that deterioration as much as we can right now and make things better for this patient right now. We've seen maintenance programs that have been billed to Medicare and have been years and years of the exact same thing and no changes. Just because the patient maintains at a specific level doesn't mean it requires skilled intervention anymore. So some of the things in the documentation for maintenance. What's the complication or complexity that's putting this patient at risk for further deterioration? What specific skilled interventions are you going to be providing? Are you documenting that education that you are giving to the caregiver? Is there indications that the care is skilled maintenance in your documentation? And of course, your documentation again needs to be accurate and objective and measurable and complete, etc. So let's kind of round out the day by talking about some of the common findings that we find when reviewing outpatient services. Excuse me. So we often see that the documentation is lacking. So initial evaluation or necessary reevaluations are not included. Sometimes we don't get the certification, progress notes, including discharge and daily treatment records. Either these are under-documented, so they just really don't contain adequate information, or they're not supplied to us at all. So we get part of the chart, but not the whole chart, which is more in the lines of missing documentation. So failure to document continued need for the patient. Maybe the patient has plateaued in their progress and there's been no changes to the plan. How are you working through that plateau? Those can be things that are just missing or not adequately documented. These kind of are lack of documentation and missing documentation kind of overlap with, you know, going back and forth, because are we just short? Did we just undersell ourselves, or did someone forget to supply it? Progress notes that are not completed by the therapist or not completed every 10th treatment day. Those can fall into a denial under missing documentation. Vague justification of medical necessity. So services that are just not skilled in nature. So they're not services that are improving the patient's current condition or maintaining or preventing deterioration. Your justification of medical necessity is not evident in the documentation. There's no diagnosis. We don't know who administered the services, goals that are not being met with no rationale as to why or what you are doing to change or update those goals to get that patient to, work through those goals. Maintenance without justification is another issue. So we talked about maintenance a little bit, and we talked about some of the things that you need to do as a therapist to provide a maintenance program. And again, it needs to be established by you. It has to have skilled interventions. Those skilled interventions can only be done safely and effectively by you or under your direct supervision. And you have to show us what you're doing to maintain that patient's function or slow or prevent that deterioration. And then you get out. Again, you don't just carry it on for years and years without any kind of reasonable and necessary information on why. All right, and then finally I want to talk just briefly about the KX modifier, which we did have a whole webinar on just maybe in November, and I talked about the KX modifier and therapy services, and I just want to remind you it is a billing modifier, but it is pertinent to outpatient therapy services. So it's an annual per beneficiary incurred expense amount. And by putting it on your claim, you're actually attesting to the medical necessity of working or providing skilled therapy services above those yearly threshold amounts. So it's required that the information is on your bill to Medicare, and that serves as your attestation, and that your documentation is really supporting why those skilled services continue to be medically reasonable and necessary. So for 2024, since we're just starting 2024, the KX threshold amounts are $23.30, and that's combined for PT and SLP, and $23.30 for OT. And remember, there's a second threshold, and that threshold is when you hit the 3,000 mark. And that's when manual medical review could happen to your claims. Now, this 3,000 amount is not going to change until after 2028. So it will stay that amount. But these amounts for your KX threshold, when you first have to start putting it on your claim, start at $23.30, again, here for PT and SLP combined. And again, they'll change every year. All right. So when the beneficiary's incurred therapy expenses qualify for the KX modifier threshold amount is when you need to start putting it on your claim. So what this means is when you're doing outpatient rehabilitative therapy services, someone needs to be looking up the patient's actual amounts of therapy expenses that they have incurred for the year. And that can be done through our portal, through our IVR, et cetera. So you have several options on how to look up how much the patient has used for the year. So that was a lot, and that leaves us a little bit of time for questions, and I don't see any in the chat right now, but if you have a question on anything we talked about, go ahead and throw that in the chat while I am, finishing up with some of our closing remarks. So I threw a lot of information at you today, and some of it is a review for those of you that are older and have been doing Medicare for a while, and some of it's brand new information that could be very much overwhelming for you that are new to the Medicare system. So we went through those basic criteria of coverage and those documentation requirements for Medicare for outpatient therapy services. And then we talked about a little bit about some of those pitfalls that are identified in medical review, some of those common findings that we're having. And we did this by going through the coverage criteria and the documentation and the common errors and solutions. So again, I'm going to pause here. I'm looking over at the chat, and I do not see any questions, so I am just going to move on. At this time, I want to thank you all for participating in today's event. On behalf of myself and all of Provider Outreach and Education and our Medical Review Department, thank you for taking the time to listen to this education, and you may now disconnect.